Yes, again, the answer to this question is yes. In all de novo patients, it's a challenge to look at their hemodynamics, but once they are monitored, while you should know that most of these patients and could be started on ARNI pre-discharge. In fact, many of these can be given this medicine during hospitalization, and of course on discharge ticket you should have this molecule, because the de novo patients also are likely to live longer and free of re-hospitalization when ARNI is started pre-discharge. So, initiation of sacubitril was studied again in patients with newly diagnosed or de novo heart failure, and this is a subgroup of transition study which showed that echocardiographic parameters in hospitalized HFrEF were improved significantly. There was a reversal of remodeling in these patients, and both of these was significantly better as compared to ACE or ARB. This you can see biologically, biochemically on a reduction in T levels in these patients. So not only that, more de novo patients would achieve a target dose at week 10, and fewer had serious side effects or permanent treatment discontinuations, again as compared to ACE or ARB. So it's easy. It's better to start a ARNI pre-discharge in these patients. It's better in terms of results as compared to ACE and ARB, and it is also better in terms of tolerance. So always consider ARNI to be the first line again in these patients who are presenting with de novo heart failure to prevent further progression and sudden deaths. So the 2021 update on consensus pathways again shows down of being first drug advantage now sits over the head of ARNI and not on ACE or ARB. Then of course there are certain of these molecules start here again. I would like to focus on this particular part of the slide which shows that black patients despite ARNI or beta blocker will receive a hydroxyzine isosulfide dinitrate. Why I'm focusing on this is that I see very frequently patients receiving nitrate hydroxyzine combination in India for heart failure when ARNI has not even been tried or tested in them. Remember, the drug of choice in everybody except black is ARNI. Even in blacks, ARNI has done better, although ACE and ARB are not seen to be working in this particular racial group. Here is that molecule which has shown that mortality can be reduced. In Indian race specifically, I wouldn't say that we have any robust data for nitrate and hydrogen combination. So always stick to ARNI or ACE or ARB. So a given period of 3 to 6 months should be the maximum wherein you can achieve the standard and target doses. So always consider ARNI to be the first line therapy, and always give them precedence over ACE and ARB.